My name is Dr. Barry, and I'm going to be speaking with you today about Lyme and tick-borne disease. So I do not have any financial arrangements or affiliations with any of the commercial entities discussed in this talk. Just as some background, I serve on the Carlisle, Mass. Board of Health, as well as the Lyme Disease Subcommittee. I have a private practice in Concord, Mass., and I went to medical school at NYU, did my internship and residency in Boston at Beth Israel Deaconess Medical Center. So why do I care about Lyme disease? My son presented to me when he was 6 years old with this diffuse rash, as you can see right here, all over his torso one morning. And this is early disseminated Lyme disease. These are bullseye rashes. He had been lying on the couch feverish for about a week, about a month prior to this rash. So just as a quick note, if you do have any symptoms of flu-like symptoms, fever, neck stiffness, things like that, certainly suspect Lyme disease if this happens in the summer. Certainly COVID has changed that a little bit, but definitely keep your radar out, look for Lyme. And these are more photos that I took of my son. You can see he's got these very faint circular lesions. These were all over his body. Some are solid, some have central clearing that are more typical of the bullseye. But as we discuss in a minute, the bullseye rash, the presenting rash of Lyme disease, is not always the typical that you think of in a textbook. So just to go over, Lyme disease cases have been increasing significantly over the past 20 years. As you can see here, they were primarily clustered in the northeastern United States, a few cases out in the Midwest, and really not seeing much elsewhere. 2015 and today, it looks pretty similar to this. You see this might be a little more dense. These two areas are starting to join, and you're starting to see a larger distribution of the ticks that carry Lyme disease. And just in terms of this distribution by age, we see a bimodal type of distribution. You see younger people presenting, so typically 5-year-olds, just like my son. He was about 6. And then later on in life, we see around middle age, people around 45, 50 tend to present. It's not really clear why. This might be related to activity, being outside. It's really, people have theories, but there's really no specific reason. This may have something to do with the immune system, but this is just something that has been noted for a number of years, that these are the kind of two groups that you see larger numbers of cases of Lyme disease. And just looking at Lyme cases by month, and this is acute Lyme disease that we're talking about, typically presenting with a rash or fever or stiff neck, things like that. You can see how between May and July, this is the greatest activity of the nymph. The nymph is thought to transmit most cases of Lyme just because it's so small, and people often have no idea that they've even been bitten. And just a quick overview of the tick life cycle. The Ixodes scapularis is what carries Borrelia burgdorferi, the causative agent of Lyme disease. It's a 2-year life cycle, so it's pretty complex, and the tick has to feed 3 times. So you have the larva, the nymph, and the adult. So each time these feed, the larva typically feeds on the mouse or birds, smaller animals. The nymph can feed on humans or other small animals, and the adult typically is thought to feed on deer, but also on humans, and then it lays the eggs and starts the cycle all over again. So it's good to understand this cycle when you are treating your yard and you're thinking about just your preventative measures that you're going to take to prevent being bitten by these organisms. And just a quick note on the spirochete itself. It is thought to be extremely old, and it has a very complex genome. This is just an article from 2014 where there was a fossilized tick was found to have Lyme spirochetes in its midgut. And it wasn't specifically Borrelia burgdorferi, but certainly spirochetes have been around quite a long time. And just in comparison, humans have, or Homo sapiens, have only been around for about 200,000 years. This was about 15 to 20 million years ago. So you can see how this organism has been evolving for quite some time. Now, what do we mean by Lyme disease? When we talk about Lyme, specifically, we're talking about the Borrelia species that can cause a constellation of symptoms that meet the criteria of what we think of as Lyme disease. And I'll get into the symptoms in just a minute. But when I am talking about Lyme and my patients are talking about Lyme, we're often lumping in the co-infections. So we're often, even though a lot of people don't even check for this, they often get lumped in because we're really talking about tick-borne disease when you're talking about Lyme disease. There's quite a bit of overlap in terms of symptoms and even treatment. The other thing that that gets overlooked is this chronic inflammatory response syndrome or immune dysfunction. This is frequently present with patients who have chronic or persistent infection with Lyme disease or co-infections or co-infections. The other things that we need to look for too when you're talking about Lyme disease, things such as nutritional deficiencies, endocrine disorders, autoimmune disorders, and sleep disorders. These are very common in people with persistent and chronic symptoms. So the definition of Lyme, the treatment of Lyme and tick-borne disease is quite variable depending on what doctor you see. And one of the reasons for that is there are two major camps in medicine in the United States. The Infectious Disease Society of America, this is the IDSA, they attribute chronic Lyme symptoms to post-treatment Lyme disease syndrome, which is, by their definition, not an active infection and does not warrant treatment with antibiotics. ILADS, on the other hand, is a group of doctors that believe that this is, in fact, an active infection. If you are treated with the CDC recommended protocols and you still have symptoms, it's still appropriate to treat with antibiotics because this is still an active infection. The other important part of the way ILADS treats and addresses Lyme disease is that they really look into the co-infections, and these really are quite common. And so just as a disclosure, this is really the camp that I fit into more than IDSA. Certainly both groups have valid points, but this is really becoming the kind of more solid way to view Lyme and tick-borne disease based on current research, and I'll show you in just a second. So the IDSA basically says that the chronic symptoms, if you've been treated with 14 days of antibiotics such as doxycycline and you still have symptoms, those symptoms are likely due to some kind of inflammatory response that occurs after the initial infection. ILADS, like I mentioned, states that this is truly an active infection and that the treatment is indicated with combination antibiotics. There are many studies that support this particular perspective where it's an active infection. Back in 2011, Dr. Eva Sappi published an article about Borrelia biofilms and resistance to antibiotics. And she clearly demonstrated that the biofilm is one of the major sources of failure to respond fully to these just short, brief periods of antibiotics. These can be effective in the acute infection, but with persistent ongoing infection for months to years, oftentimes the biofilm becomes an issue. And this is common of many different types of infections, not just Lyme disease. Monica Embers, she did some research looking at monkeys who had been, quote, effectively treated or properly treated for Lyme, and they clearly demonstrated persistence of Borrelia in their system after the appropriate treatments. And then Lyndon Hu here at Tufts, he demonstrated that people who had actually been treated, quote, appropriately for Lyme disease and had been diagnosed with the Lyme, but still had persistent symptoms, when they were presented with clean ticks, naive ticks that had no pathogens in them, the Borrelia actually found its way into those ticks. And so when you actually tested those ticks, they became positive after being exposed to these people. So that was very interesting. That was 2014. There's been a great deal of research since that time to also support this way of viewing things. And in terms of testing, there are many different tests out there. Just as a note, in general, the culture is considered the gold standard for most of infectious disease. Unfortunately, for Lyme, it's really nearly impossible to culture Lyme. It's very fastidious and it's very difficult to culture, so that's really not very helpful. So that's one of the reasons we really don't have a gold standard test at all. PCR testing for Lyme can be helpful in early infection. Generally, in my patients who've had symptoms for months, I'm not going to be looking to check their PCR because it's not going to be helpful. And antigen testing is still considered experimental. Now, there is indirect testing, such as antibody-based tests. This is what we are familiar with. So most people get the ELISA, the IFA, Western blot, or immunoblot. This really depends on your body's ability to make the antibodies. So if you have low levels of certain types of antibodies, you might get a false negative test, and that I do see quite a bit. Then there are recombinant or synthetic antigens, such as the C6 peptide ELISA, and these are just not as commercially available, so I don't typically use that very frequently. And other tests that I use, I've highlighted and read the tests that I use quite a bit. The FISH test can be very helpful, especially for Babesia and Bartonella. And the CD57 I occasionally throw into the mix because that can actually tell me what the picture looks like for someone's T cells and how robust of a response they have in terms of T cells. ELI spot testing I do use occasionally. It's not FDA approved for Lyme disease or co-infections yet, but it is something that shows some promise. I found it's kind of inconsistent, but I do occasionally consider using it in certain circumstances, and certainly xenodiagnosis is experimental. So to talk about the currently recommended two-tier testing for Lyme disease, they've recently modified it to have a modified two-tier testing. So previously they recommended the enzyme immunoassay with a confirmatory Western blot. Now you can either do a Western blot or another enzyme immunoassay to confirm. So this is what's recommended by the CDC. The unfortunate thing is that this is indirect. So it really does depend on your body's ability to make those antibodies and respond appropriately. So ironically, what I find is people that are relatively healthy and often relatively young, they actually show up with really positive tests. And so that can be very helpful. The problem is when someone who presents to me with a couple decades of symptoms, they might be in their 50s or 60s or even 40s, these antibody responses can be equivocal or indeterminate, and they're sometimes just mildly present, and they don't meet the CDC criteria because you have to have a certain number of positive bands for a positive Western blot, for example. So as you can see, the sensitivity here, the sensitivity is what we're looking for in terms of being able to pick up cases of Lyme and say, your symptoms are likely due to Lyme. So it's really, really can be very low depending on the circumstances. Even 67% at the higher end is not great. The specificity is pretty good. So if we're looking at if you have a positive test, how valuable is that? That's the specificity, and that can be very helpful. So if your doctor checks it and it's positive, that's great. Then you kind of have that information and you say, I've been exposed to Lyme. Whether or not it's causing your symptoms is a whole different question. So just in general, even though this is what is recommended by the CDC, neither of these tests are sensitive enough to really rule out Lyme disease. So this is the reason that in Massachusetts, the diagnosis of Lyme disease can be made on clinical grounds alone because the testing is just not adequate at this time. And it also cannot be used to determine a cure. So after you've been treated, you really cannot use this as a gauge to see if you've responded appropriately. And just another quick note about the Western blot. This is an example of a Western blot. These are different patients. What you do is you put the sample, the prepared sample up here at the top of the column. This is a gel, and there's a charge in this gel, and it basically allows the proteins to separate out. So these represent different sized proteins. So that's what the 41 kilodalton, 39 kilodalton, these are different sizes. And as you can see, they kind of blur together. And so it can be very subjective. So if a tech at a lab is looking, they might say, ooh, this is a positive band. Whereas the next day, a different tech might say, oh, that's more of an indeterminate or weak positive band. So you can see how there's quite a bit of variability in terms of the traditional Western blot. And as we mentioned earlier, there's quite a range of sensitivity. It's not the best test for really picking up Lyme disease. And there is some laboratory variability in terms of the definition of a positive test. The CDC does also say that the IgM is only valuable in terms of interpretation if your symptoms have been present for less than 30 days. So they throw it out the window. And so this does result in a good number of people that are just not, who do have Lyme, they just aren't showing up positive by CDC criteria. And this is definitely a bone of contention between ILADS and IDSA in terms of defining what is a positive test. So problem number one, there are many Borrelia species out there that can certainly cause disease. We know of a handful that we test for. There are probably many others that we haven't even identified. But testing is specific for each. And most commercial labs use the B31 strain of Borrelia. That's the, if we look at LabCorp or Quest or local hospitals, they're using the B31 strain. IGeneX in California is a specialty lab, and they have been using B31 as well as 297 and the European strains, Borrelia afzelii and Borrelia greenii. So that you can see this is one of the reasons that if you get a positive at IGeneX, you might get a negative at LabCorp with the same exact blood sample. The other thing is Borrelia miyamotoi is a pretty common pathogen that I've been seeing in a lot of patients in the Northeast United States, and it is a separate test, and so you have to order that outside, even at IGeneX, you have to do a separate test for this. And there are many other species, like I mentioned, that are just not commercially available yet. And here is a phylogenetic tree. You can see there are a number of different species in different parts of the world. So Borrelia japonica, you can see is in Japan, and there's a nice map that I did not include here because it's just out of the scope of this talk, but this just gives you a sense of how many species we're looking at. Here's miyamotoi down here, which I've been seeing a number of patients in our area, and then the European strain up here. So these all have separate tests, and so if you're negative on one, you may not be positive. There may be some cross-reactivity, but for the most part, they're separate tests. The other thing is tests don't exist in a vacuum. You have to look at the overall prevalence in your area. So just as an example, Lyme in Massachusetts is, my best guess is that it is extremely common. And it's almost misleading because there are a number of people who may have very mild symptoms or almost no symptoms at all, but they can have positive tests. So that can kind of mislead you to thinking that there are false positives out there. They may actually be exposed to it, but they may not have clinical manifestations and actual Lyme disease per se. Whereas looking at Ebola in Massachusetts, that's going to have certainly a different prevalence. And so you interpret the tests very differently based on the background prevalence of a disease. The other thing that I mentioned before is some patients have very poor antibody response. There are a number of reasons for this. It could be genetic. It could be exposures to environmental factors like mold or mycotoxins that can suppress your immune response, or even just having had Lyme slash tick-borne disease for a number of years. Your body kind of peters out and it gets this B and T cell exhaustion where your body just doesn't really mount a really good antibody response anymore. So this is part of what I look at when I see a patient. I do look to see what their total IgM is and their total IgG so I can actually interpret the test. A lot of people don't do that. Some do. But I do feel it almost should be kind of standard protocol. To be able to interpret a Lyme test, you should look at the baseline total numbers for these. And like I mentioned, we really don't know the true prevalence of Lyme disease. It's probably far more prevalent than we really give credit. Now, why is the medical community divided? I think part of it is just it's a pretty complex topic to talk about. It's evolving. There's definitely active research happening that's kind of changing the perspective on testing and persistent infection and many other co-infections that go along with Lyme. One major problem is that early and late disease look very different. So if you were to take someone with early disease, this is what you learn about in medical school. So, and I'll show you that in just a second with some slides. You get the bullseye rash, you might get fevers, you might even get a swollen joint pretty early on. But late disease can be very, very different. And that's typically what I'm seeing in my practice. Because people go from one specialist to another and don't get any good answers, still feel sick, and you really have to dig deep to find this if you're not suspecting it. Testing is technically complicated, as we already discussed, and there is low sensitivity for the CDC two-tier testing. There really is no true gold standard test, as we talked about. Symptoms are vague, so symptoms can overlap with a number of conditions. And one of the things you need to keep in mind as a clinician looking at this and treating this and diagnosing this is you constantly have to be looking for other causes, because you don't ever want to make the mistake of saying everyone has Lyme, because the symptoms are extremely nonspecific and you really need to look at a pattern recognition. And this is why we do use testing. We use testing to confirm our suspicions and go after what we think may be happening. But yes, they are very, especially in late disease, the symptoms can be very, very vague. So the typical manifestations, I love this just cartoon character thing. It's just super old from the CDC. I don't even know if they still have it on their website, but it's just, a goofy looking cartoon showing you this is what the medical student learns is you look for this, the bullseye rash somewhere in the body. This is a pretty big bullseye rash. Facial palsy, you can look at, one-sided weakness and then a swollen joint. So this is a pretty simplistic view of Lyme disease. And some examples of the bullseye rash, this almost looks like someone took some lipstick and drew this on their back. It's just so robust and so clear. It would be hard to mistake. This really is a rash, although this is on someone's back, and so they may not even notice it. But if you went into the ER and you had this, a doctor would know what's wrong with you. This is really pathognomonic and in this case, this person has multiple EMs, so this would be early disseminated. Here's another bullseye, very clear, pretty obvious. If you look at these are EM rashes, and this is also from the CDC website. These are great examples of subtle EM rashes. So this is behind someone's knee. It's just some darkening, and sometimes they're accompanied by a little discomfort, swelling, itching. And those aren't often described when people learn about Lyme disease. You do get some itchiness and discomfort and maybe a little throbbing. So this is a very subtle presentation. And certainly in people with darker skin, it can be very hard to see. And here in this case, you have a little bit of a nodule. You can clearly see some swelling, and it's not even that big. It doesn't have to be terribly large. It doesn't have to be the textbook rash that you think of. Here's another example. where the rash, you can see the edge expanding. And this person is lucky enough that they picked this up, because I would imagine most people wouldn't even notice this. This is barely visible. But maybe it was associated with a little discomfort, and so that might have been a trigger to go see their primary doctor and have it evaluated. And someone clearly had a good eye and picked this up. This is another different type of rash. This was also Lyme. This is another example where it's not a typical presentation. It's solid. You can see this is where the tick bite was. And the edges are not your typical kind of smooth edges. Here's another one where it's very subtle. You can see there's just this arc here, and it could have been easily missed. Here's another solid rash. It's probably warm, possibly tender, maybe itchy. And here's one that's very pale with some central clearing. And another example of a very subtle one on an infant. Some more EM, multiple EMs. So just keep a lookout if you happen to get one of these. Just low threshold, take a photo of it. Have a low threshold for seeing your doctor and mentioning Lyme disease, because they may not even think of it, especially if it's not the right time of year. So looking at early versus late / persistent Lyme. So early, you're going to be seeing flu-like symptoms. You might have fevers. You might have neck stiffness, malaise. You might feel tired, just kind of want to stay in bed and feel yucky. And not always the bullseye rash. You might have a tiny little rash on your scalp. You might have one on your back. You may not notice it. And it might not be very big. So in terms of persistent symptoms, these are some, and I have an even longer list on my next slide. There is a very, very long list of possible symptoms. So the facial paralysis, quote, Bell's palsy, it's really not Bell's palsy, but it's just facial paralysis, very, very common. So in Massachusetts and the Northeast US, if you have facial paralysis, you really, really, really need to think of Lyme disease at any time of year. Arthritis, typically knee, but any joint can be affected. And in persistent disease, you're often seeing migratory intermittent arthritis. But people can have solitary arthritis as well. Arrhythmias, you really, and especially a young person who presents with an arrhythmia, you really need to think of Lyme disease. Unexplained fevers, chills, sweats, chest pain, rib soreness, muscle pain and cramps, fatigue, stiffness of the neck or back, stomach upset, reflux. I do see a lot of GI symptoms, IBS type things, shooting pains, numbness, tingling in the hands and feet, headaches, neck stiffness, tendon pain, tendinopathies, palpitations, tremors, visual changes are very common, irregular menses, even infertility, sorry about that, forgetfulness, mood swings, irritability, lightheadedness, and orthostatic hypotension, endocarditis, myocarditis, heart failure. Those are more extreme, not typically seen, and thyroid dysfunction I do see in quite a number of my patients. And really, it is a pattern recognition, and you really need to think of it. So if you're out there seeing patient after patient after patient, and someone comes in with these non-specific symptoms, not everybody thinks of Lyme. Some of the things that really I consider red flags for Lyme disease, migratory joint pain. If it's moving around, you're constantly involving different joints, you got to think of Lyme disease. Orthostatic hypotension, POTS. I see this in a lot of young people. If there's no other cause, you really do need to evaluate for Lyme and think hard about why they might be having this. You can get autonomic neuropathies. You can also get adrenal insufficiency with Lyme disease, just like you would with tuberculosis. So certainly keep that on the radar. Insomnia, especially treatment-resistant insomnia, I see in a lot of people. Very common with babesiosis as a co-infection. Overwhelming fatigue that is just unexplained. Certainly, this is, fatigue. You really want to look out for other causes. You want to make sure that people are up to date on their appropriate screening and make sure that their labs look normal. It's many things cause fatigue. Lockjaw. So a lot of people with Lyme disease co-infections get this kind of trismus, this tightening of their jaw, where they can get TMJ pain, but you just get this muscle spasm and muscle spasticity in your jaw. And facial weakness, like I mentioned earlier, if you have that, you really, really need to think of Lyme disease. And it is a multi-system infection. When we think of early disease, it's really, I say in my head, I think it disseminates very quickly. So after the initial tick bite, within a few weeks, you're looking at it's definitely spreading. It goes to your nervous system very quickly. So you're going to see a lot of people presenting to neurologists. It loves the joints. You're going to see a lot of people going to rheumatologists, ophthalmologists, the eyes, especially Bartonella, and gastroenterologists, interestingly. And orthopedists as well, obviously. So I see people referred by a number of specialists, and most of my patients have been seen by 2 or 3 specialists, if not many, many more. So why is Lyme so hard to diagnose and treat? It really knows how to hide. So here you have a picture of a leaf bug, which I thought this was just a cool picture, but it hides in your body. And there are many ways that it does that. One of them is it can exist in a biofilm, and it can be very hard to break up. So antibiotics just barely touch biofilms. They may get a few little guys on the outside, but it really cannot penetrate into this big mass of these are spirochetes, and they're just kind of clumped together. But biofilms can have multiple pathogens. They have mucopolysaccharides in there, and it's just a big clump of pathogenic material that just kind of hides out in your body and just sits there. And if you think of biofilms, first thing in the morning when you wake up before you brush your teeth, people have a little bit of a slime layer on their teeth. That's a biofilm. And so most bacteria form biofilms. And Borrelia itself can exist as a spirochete, which you see here. It can exist as a cyst, which is more hardy and much more difficult to treat with antibiotics. That's the kind of dormant phase where it just sits lying in wait until an insult has passed, such as doxycycline, for example. And then the biofilm. It also exists as intracellular form. So it actually goes into your cells, including your white blood cells, just like HIV would. It infects your cells. It interferes with the complement cascade. It has shown resistance to host antimicrobial peptides such as lactoferrin. And these are just some examples of the mechanisms that Borrelia uses to evade your body's immune defenses. It disables germinal centers in your lymph nodes. So when you get this lymphadenopathy, your lymph nodes swell right with your acute phase of your infection, early disease. And it actually changes the architecture, and it can make your lymph nodes dysfunctional. So your B and T cells aren't working properly. And so that long-term can lead to some dysfunction of your antibody responses and other branches of your immune system. It also can interfere with thyroid function, such as reducing your body temperature, which further impedes your body's immune system and activation of your white blood cells. So just a note on Borrelia biofilms. This is from the work of Dr. Eva Shapi and at the University of New Haven. And it shows that prolonged treatment can be necessary, especially with combination antibiotics, because of these biofilms that exist. These are different images of biofilms of Borrelia. And like I mentioned earlier, it kind of exists in this congealed mucopolysaccharide glob inside your body, and it can have many other components such as heavy metals, fibrin, to protect it, almost like a castle. And within these biofilms, different organisms can exchange genetic material, which is not necessarily a good thing. They can exchange resistance plasmids and things like that. So talking about co-infections. So co-infections are critical to diagnosis and treatment, proper diagnosis and treatment. Some lucky people might, with a pretty good immune system, might just get Lyme disease, and if you treat them with doxycycline, they might just get better. A good number of people, however, if you don't look for and treat the co-infections, they're going to develop persistent disease. And this is one of the major reasons people fail proper regular treatment with the recommended CDC protocol of doxycycline. So Babesia is very common. I see this in a lot of my patients, and there are different types of Babesia. So even if someone is checked for Babesia, there are a number of different Babesia species that are not even commercially available for testing. And I do suspect that a number of my patients who are just not coming back positive, but clearly have a lot of Babesia symptoms and may even respond to Babesia treatment, are falling into that category. Babesia duncani is very, very difficult to treat, and that is something that I've been seeing increasingly in my patients in this area. Bartonella, that is an interesting pathogen, and I'll go into the symptoms of each of these, what to look for in just a minute. These are actually pretty common. I picked this up. You just got to look for it. Anaplasma, Ehrlichia, Rickettsia, they can be very serious. However, these typically respond pretty well to a quick course of doxycycline. So even if you give doxycycline for 14 to 21 days, these typically clear up pretty fast. So that's one of the reasons we like to use doxycycline initially, because you're going to clear out a lot of this other stuff. Mycoplasma, this is something that you really have to think of, and so I just routinely check it in all my patients. It is considered a Lyme co-infection. It is a common respiratory pathogen, typically causes URI symptoms and walking pneumonia. But it has been found in ticks, and it is thought to be transmitted by ticks. Not really clear why some people get persistent infection with this. That is yet to be determined, but I do see this in a number of my patients. And Chlamydophila species as well. This kind of falls into the mycoplasma. These are atypical. These are intracellular pathogens. And Powassan virus is another one that kind of can complicate things. And there's a long list of other co-infections that are possible. These are the more common ones. So like I mentioned, diagnosis and treatment can be more difficult with any of these co-infections. These organisms have co-evolved with Borrelia. So they work synergistically to suppress the host immune system. And there is a possibility that some of these, such as maybe Bartonella, might be reactivation, Epstein-Barr virus 2 and HHV6. Not really clear if these are truly transmitted with Borrelia and Babesia. So Bartonella, for example, has been documented to be transmitted by fleas. And with cat scratches and other modes of transmission, but it's really not clear. Maybe it's just in our system already, and our immune system takes a hit, and the Bartonella then becomes active. So that it's really not quite clear how the Bartonella gets there, but it certainly does become active. So Babesia is something that is typically thought to infect your red blood cells, but it can infect other cells as well, such as your endothelial cells, the cells that line your blood vessels. And the hallmark symptoms of Babesia, this is my personal list. I mean, a lot of other clinicians kind of feel this way as well, but there are a number of other symptoms you can see with it. Typically, you see significant fatigue. So my patients are sitting in front of me, falling asleep as I'm talking to them for only 5 or 10 minutes. I immediately think of Babesia, because these people can't even keep their head up. They sleep and sleep and sleep. They might sleep 15 hours, 20 hours a day. They're just constantly tired. Sweats. Not everybody has it, but a good number of people do have sweats. Shortness of breath. Not everybody has it, but and it can be very mild. I have had people who are marathon runners who have Babesia, and they run and they exercise, and they're clearly positive. They've had positive Babesia fish tests, which you can't really argue with that. So symptoms can be very mild. And insomnia, especially treatment-resistant insomnia. I see that in a lot of people with Babesia. Certainly you can get musculoskeletal aches and pains. You can get ear pain. You can get a kind of a centralized headache behind your eyes. There are a number of symptoms that can be associated with Babesia. Bartonella, typical symptoms, and this is not exhaustive, psychiatric symptoms, anxiety, severe depression, psychotic symptoms, people who are in and out of psych hospitals, you really need to think of Bartonella. Neurologic symptoms, if someone is unable to walk, if they have severe neuropathy, burning feet, they can't walk on their feet, migraine headaches, especially intractable or headaches that don't respond to treatments offered by neurologists. Eye pathology such as uveitis, retinitis can be seen with Bartonella. Prominent, bizarre stretch marks like these purplish, these don't look like normal stretch marks. And when you actually biopsy them, you can see, you can identify and stain for Bartonella. But this is not, typically commercially available. That's only in the research area. Foot pain, like I mentioned, insomnia, muscle spasms. And interestingly, I've seen a number of people with Bartonella positivity testing positive for new celiac disease. So I do wonder maybe there's some cross-reactivity. And even some of those people have gone on, actually most of them have had confirmatory endoscopy and they truly did have celiac. So you wonder if maybe Bartonella is kind of spinning off some autoimmune phenomena triggering celiac. And something to consider, about 10 to 50%, it's a lot, of patients treated properly by CDC guidelines do develop persistent symptoms. Current guidelines recommend only 10 to 21 days of a single antibiotic, whereas Borrelia is thought to have a 4-week cycle of reproduction. And so in general, we really want to be treating beyond that 21-day window. And so treatment for persistent Lyme disease, like I mentioned, you really want to identify and treat the co-infections. You really want to treat accompanying sleep disorders, endocrine, nutritional disorders, any immune dysfunction, looking at biofilm and cystic forms. And so that's where combination treatments come into play. So you typically don't treat with just one antibiotic. You use combinations that have some activity against some of those more dormant forms, and use some non-traditional antibiotics to hit the biofilm form. What if you're bitten by a tick? What do? You remove and identify the tick. You send it off for testing, and I'll show you a list in just a second. You consider antibiotic treatment if appropriate, monitor for any new signs and symptoms, and definitely take a photo of any rash, because rashes can come and go, and you really need to show that to a treating clinician. If they see a rash, they will treat you with antibiotics, because that is a defining factor for Lyme disease if you have an appropriate rash. So as a note, post-exposure prophylaxis is recommended by the CDC. A 200 milligram dose of doxycycline after an Ixodes scapularis tick bite in an endemic area. This is really old. Like, this is based on a study done years ago, looking at giving either 100 milligrams or 200 milligrams, either 1 or 2 doses after a tick bite. It seems to reduce the EM rash, but it does not reduce the transmission of pathogens. So people go on to develop persistent infection. And the unfortunate thing is they don't get a rash, so no one even knows that they have Lyme. So you're going to develop these bizarre, just vague symptoms that go on and linger, and you don't have a good history of a rash, and you also go on to have a seronegative disease state, meaning it kind of turns down your antibody response. So taking this single dose is the worst thing you can possibly do. The ILADS recommends treating with doxycycline for at least 20 days. Consider a longer course if you have symptoms or if you have other reasons to treat for longer. Monitor for any symptoms of co-infections and of Lyme disease, and consider antibody testing or other types of testing for co-infections. And as a note, if you are intolerant of doxycycline or cannot take it for some reason, these antibiotics can be substituted. So what do you do if your Lyme test is negative, but you think you have Lyme disease? I typically recommend people sending off tests to IGeneX in California, looking for the Lyme immunoblot, tick-borne relapsing fever immunoblot, as well as Babesia species IFA and fish, and Bartonella western blot in fish. So these can be pretty expensive. You can get reimbursed by your insurance company because these are all regular FDA-approved tests. There's nothing experimental about these. I also send tests off to Quest for Mycoplasma and Cliniphila pneumonia, CD57 Lyme at Quest, and these are also should be covered by insurance. CBC with differential. What I do look for specifically with the differential, not everybody does the CBC with diff. I look for high eosinophils and possibly a low white blood cell count. These are things I don't see it in everybody, but I do see it in a number of people with persistent infection, especially the low white blood cell count. And I do get baseline total IgG, total IgM, and total IgA, just to see what we're dealing with in terms of your body's ability to make antibodies in general. I also check inflammatory markers, C-reactive protein, and sed rate. And depending, more and more, I've been checking this on my patients with persistent symptoms, urine mycotoxins, to look for exposure to mold and mycotoxins. And Real-Time Lab in Texas is one of the labs that you can use for that. How to improve symptoms. So I usually recommend a low-carb Mediterranean-style diet, avoid processed foods, and try a period gluten-free, because a lot of people with Lyme disease, even if they're not celiac positive, they do respond to a gluten-free diet, and they do feel a lot better. You can raise your body temperature with moderate exercise, sauna, sweating. Some people find that anti-inflammatory supplements are helpful, such as fish oil, curcumin, quercetin. Stress reduction. People absolutely note that stress seems to make all of their symptoms worse. So they go on vacation, they feel great, they come back to work, and they wonder if there's something wrong with their work. But it's just stress. It can actually impair your immune function, and just it drives inflammation in a subset of people. So I do recommend meditation. Meditation, interestingly, has shown to be very beneficial in the people that are motivated to do it. Breathing on a regular basis. There are breathing exercises that you can do, and certainly just socializing, which can be tough during COVID pandemic. Sleep hygiene and supplements such as melatonin, L-theanine, magnesium can be very helpful. And look for nutritional deficiencies. So check your vitamin D. You can empirically take magnesium, or you can check red blood cell magnesium. Sometimes I'll check red blood cell zinc. A lot of my patients are low on zinc. And I do identify a lot of B vitamin deficiencies, such as folate and B12. Sometimes B6, not as frequently. And certainly I do treat with antibiotics when appropriate. People who don't tolerate antibiotics, sometimes herbal or non-traditional antibiotics can be used as well. But certainly discuss any of these with your physician before embarking on any kind of treatment protocol. Diet, like I mentioned, gluten is a huge trigger for inflammation in a subset of people. Not really sure why. It seems like a lot of my patients who are not celiac positive, who cannot tolerate gluten in this country, tolerate it in other countries such as Italy and France. And it might have something to do with the types of gluten used in those countries, or maybe even pesticides. It's not really clear. Limiting sugar can be very helpful. That really can drive inflammation. Avoiding alcohol, just avoiding any kind of processed foods is always a good idea anyway. And this can also help reduce the inflammation in your system. Focusing on high quality proteins, such as from salmon, organic chicken, limiting red meat and pork, just because this can actually drive inflammation, and a lot of people can slow down your bowels too, and that can drive inflammation as well, preventing you from kind of clearing your cytokines if you have slow bowel transit time. and just increasing vegetables and fruits, seeds, nuts. These things have actually, these recommendations have been shown to change your gut flora to favor an anti-inflammatory profile. So there are different types of species of bacteria that live in your gut that can drive inflammation or help reduce inflammation. And so these dietary changes certainly can have a huge impact on that. And then even consider an elimination diet. Some people find that that's helpful to identify certain trigger foods. Exercise. In general, I do recommend against intense training, marathon training, like, Ironman training, things like that. And I have a lot of intense, very type A patients who really like to do that kind of stuff, but it drives inflammation, and it can kind of trigger some autoimmunity as well via these mechanisms. And moderate exercise is wonderful. So jogging, walking, just whatever you can tolerate. If it makes you feel sick, don't do it. But walking and stretching daily usually is well tolerated. Some of my patients are so sick they really have trouble walking, and it can really make them go backwards. And so I tell them hold off on that for the time being. It really depends on the person. And gently raising your body temperature can certainly have a positive impact on your immune function. And in terms of treatment, so this is kind of where I come in. A lot of prescription drugs that I use for treatment, such as, these are not exhaustive lists, but these are examples. Certain combinations, pulsed and sometimes continuous, depending on what kind of testing you show. Doxycycline, minocycline, azithromycin, cefuroxime, metronidazole, rifampin, etc. These are often used in combination in different ways to kind of kill Borrelia and the co-infections. Herbal antimicrobials, I've been incorporating a lot of oil of oregano, and certainly pulsing artemisinin quite a bit with my Babesia patients. Low-dose naltrexone has been used more and more for chronic inflammation. It seems to just kind of turn the dial down a little bit, and it can be very effective for people with thyroid problems and thyroiditis. Citrus pectin I use in a number of patients as a binder to help reduce some of those inflammatory cytokines. Certainly vitamin D, zinc, even melatonin can be considered an immune modulating agent. Detoxification, certainly a lot of people I see, you treat them and they just have these robust flares and they just cannot clear it out of their system. So sometimes you really need to focus on supporting the liver and kind of being able to get all the garbage out of your system when you actually create all these byproducts of inflammation. So things like milk thistle, ox bile, glutathione, magnesium can be helpful. And just reducing inflammation, fish oil, curcumin are wonderful. And like I mentioned, LDN, low-dose naltrexone. And then many physicians are now using novel therapeutics for treatment-resistant Lyme and co-infections, such as methylene blue, disulfiram, dapsone, many different types of herbals, and desloratadine. Just a note, before embarking on any of these things, definitely consult your physician because there are absolutely drug interactions. These may not be appropriate for you if you have certain medical conditions. Now, tips for living in a Lyme endemic area, such as Massachusetts. One thing I definitely recommend is getting some permethrin spray. This stuff is very toxic, but if you spray it outside, or if you're sensitive to it, have someone else spray it on your lower pants, your socks, your shoes, let it dry. And if you get a special formulation, and I'll show you a picture of one type that I like, it can actually last through several cycles of wash. So some people have their special pants that they wear if they have to do yard work, and they just use it only for yard work, and they repeatedly spray it with permethrin on a regular basis, say every 6 cycles of wash or something like that. Create a tick-free zone around your home. So in this picture, you can see the yard is really devoid of much vegetation, which is great. It allows sunlight to come in here, and the sunlight dries up this area. Ticks do not like dryness. They like moisture. So the ticks are going to be living in the leaf litter amongst the trees. You want to create a buffer zone. You can create like wood chips can be helpful, but I've seen ticks everywhere from stones on wood chips. They basically, I've seen them in the middle of soccer fields. So all bets are off with ticks, but this reduces the density of ticks that might be making their way closer to your house and reducing your risk. Say if your children are playing back here, they're going to be less likely to be exposed to ticks if you have a buffer zone. So this is just kind of an example of one home of what you can do. Remove leaf litter as much as possible. Anywhere you, your dogs, your children, anyone in your family is going to be spending any time, try to remove that from your yard. Just keep it at bay. If you have a big yard, just keep it in the far edges of your yard if possible, because this is where the ticks live. Do not allow your cats or dogs in your bed. I don't know how many people I have treated with repeated tick bites that are positive for Lyme and tick-borne disease. They sleep with their dogs and their cats. You just can't do that. You're just a sitting duck. The ticks are just going to crawl from them onto you if they have it, and especially cats, because ticks in general do not like the blood of cats. So what happens is they might do a partial feed on a cat and then release and then go to you. And so they're already primed. And when they're already primed, they don't even need to be attached for very long because the Borrelia has already migrated from the midgut to the salivary glands. And so that can be transmitted much more quickly. So be very careful if you have cats. But even dogs, we pick dogs, just the ticks, they crawl on the dog's fur. And if you pet the dog, then immediately it just goes on to you. And again, they're primed, and so the ticks are they're warming up the minute they start walking. That they're priming themselves for a bite. And definitely keep cats indoors. Do not let your cats outside. So here are some products that can be helpful in terms of killing ticks. So this is not just a repellent. It says repellent, but it actually kills ticks. So the cool thing is it will kill a good majority of ticks before they even get a chance to transmit disease to you. So that's great. So they'll fall off, even if they've bitten you, they will often fall off before they really get a chance to do any damage. And this is specially formulated to go on clothing, which is great. But do not apply it to your skin, as it says right here. Tick tubes, you can place these around your yard in areas especially where you see chipmunks and mice, just to kill the overwintering ticks that can kind of linger and prolong that 2-year life cycle. This is a great, I love the tick spoon. It removes ticks really, really effectively. Tweezers are kind of tougher. They seem to cause more damage to your skin. This one, you just kind of get the tick in there and it scoops it right up. And I find this is my favorite way to remove ticks from dogs and humans. But sometimes in tough areas, the tweezers are necessary. And this is just a great picture of close-up of an Ixodes scapularis with the little hook you can see here. As you're walking by, they quest. These have little CO2 sensors, and they can tell when there's an animal walking by. And then they kind of stick their little hooks up in the air, and he's presumably on a blade of grass waiting for you as you're walking by. So in terms of tick testing, this is just an example of what I do when I get a tick. I put it in a piece of tape because they often say put it in an envelope, but if it's so alive that it makes me a little nervous that it can get out and kind of, infect someone in the process. So I put it in tape and then I put it into an envelope for testing. I personally like UMass tick testing. They do a great job. They have a really nice comprehensive panel that if anyone in my family ever gets bitten, we send that off. There are a number of other private labs these are all listed on the mass.gov website. And just as some resources, ILADS has quite a bit of information. This also has a list of doctors in your area that are more familiar with treating Lyme disease. LymeDisease.org can be very helpful, and there are many, many others. Thank you very much.